things aren't missed, but we'll also send a recording out if you request it, and we'll send the slides as well. And I think that's, yes, I should have said actually, sorry, that in Lindsay's piece, we will cover our model of care and sport, our life model, which is really taken off actually since the early days when we started it, and we do that right across our business now at different levels, but Lindsay will explain that. So I think that's it. I think we can get started, and I'll hand over to Chloe.
Yes. So there was a slight change of agenda, sorry to jump in there, but
Okay.
Lindsay and I run through the presentation and the flow just went a little bit better with Lindsay starting it. So I'll share my screen and we'll go through the slides, so bear with me. Oh, and Rachel, would you mind just manning the admittances? Because I can't see anything on the screen once I share, so thank you.
That's fine, I've got that.
Thank you. So I'll just share this. It's just loading. And if my camera disappears, I may have to go to the camera off just because it's stalling a little bit. So bear with me.
Yes, we've all got our trendy new backgrounds on today.
We have,
yeah. The system will implode at some point.
Let me just, because it's just stalling a little bit, so I'll just turn my camera off, which should help. Okay. And here we are. Can everybody see that?
Yep.
Quite small.
Perfect. Yeah, it's just starting now.
Starting as a slideshow.
It is. So here we are. Okay, so as Rachel mentioned, we'll go through and the life model with Lindsay and our aims as a housing and care provider, and then I'll go through our community models and some of the outcomes that we've managed to support the community with, and then there'll be a time for questions and answers. So over to Lindsay on life.
Okay, I'll just start by kind of introducing myself and a bit of background, which I think might be helpful. So I'm Lindsay Courtney, I'm Head of Clinical Practice at Home Group, and I've had the privilege of being part of New Models of Care since, or Models of Care, since it started 5 years ago. So my background is as an occupational therapist with 30 years in the NHS, and took the unique opportunity to join Home Group on this journey to really deliver integrated health, housing and social care. And right at the beginning, what we really wanted to do was to think about what our support practice model needed to look like to build our foundations around actually some really core principles, and for me, core domains that we now deliver across all our services. So LIFE is our support practice model, and it stands for living independently and feeling enabled. So this is our support practice that you will see, whether it's a clinical service with a clinician and clinical oversight, or it's a more supported service. And there's different levels of complexity that we deliver against our life. So really just to run through for you what we see sitting behind our life model. So in terms of our principles, we're really person-centered. I'm sure all of us would absolutely agree. Person-centered approach to the way we work with people is absolutely critical. But it also reminds us that if it's person-centered, one size doesn't fit all. And I hope what we will sort of talk today is very much about how each of our models is slightly different. It's tailored to individual needs. So we really work hard to deliver person-centered. We do believe the customer is the expert. We listen to our customers' voice and their choice is really important to us. And that's about working in partnership to understand what that customer would want. They aren't always able, as we'll go through some of our models, to articulate that, but how we work within their existing care providers to understand that. Psychologically informed, we work in a psychologically informed way. We deliver a lot of psychologically informed environments, so PI is critical to us, but we know that relationships are a primary tool to change. And so a lot of the work that our clinicians do is to support workers, services, reablement workers to understand the psychological impact and the importance of psychologically informed environments and psychological approach to what we do. So we really try and work to our values and be compassionate, caring as part of that. For me as an OT, it will not surprise you that the strengths-based area is something I'm really, really keen on. So we really need to focus with some of our customers who can be quite complex about what's strong, not what's wrong, and to celebrate unique gifts and talents. I think we particularly in Transforming Care, as Rachel has talked about, we work with some very complex customers, and I think it's easy to lose sight of the strengths that some people bring with them. So very much we want to understand the unique talents of our customers and to build their confidence to gain the skills that they need. We provide scaffolding to allow them to do that. But I think fundamental as well is the work we do around risk, and particularly positive risk taking. I think it's very easy to kind of lock things down due to risk, and that does not enable growth and development for our customers. So we acknowledge risk, but we really work on positive risk taking where we can. And in terms of our domains, well-being. So we look at this in two ways. Important to me, so we know for most of us, what's important to us might be our family, it might be our hobbies, it's what we do as work, it's what gets us up in the morning, those things that make us unique. We really feel that we need to work in a way that understands what's important to people, but we can't forget what's important for people. So there is that element about risk management, about safeguarding that really is important for people. And we need to balance what's important to people with what's important for people to get the best approach. Skills development, we're doing a lot of work around skills development. I'll come on to talk about our clinical workforce, but we have a lot of occupational therapists, positive behavioural support workers, all of which we are looking to develop skills development right the way through the system. So how do we, certainly was something I was very involved in, was the older persons model around community wellbeing, and trying to move from traditional delivery of support to reablement approach, to refocus that every opportunity to work with an older person in terms of delivering personal care is an opportunity to build their skills and their development, and not just to kind of do to, but to do with people. So for me as an OT, that's really important, the work we do, and balancing that with active support. Because ultimately what we want is people to have meaningful lives that fit with what they want and enable them to get the best quality. And physical health, we have a physical health expert, and we're very mindful, particularly some of our mental health customers, that physical health sometimes is not as a prominent feature. We don't always work. So a lot of the work we do is how do we enable and connect people with existing secondary care systems? How do we support people to be more proactive in the management of their health? How do we sort of set them up in their normal day life to think about diet, food, all those things that give us good health, as well as when somebody has, say, a chronic condition, how do we support our workers to work with them to manage that condition? So life is the model you'll see that underpins a lot of the models that we deliver. Different elements will take a different prominence at different times for customers, but ultimately that is our support practice. The next slide, please. I just wanted to touch on what we aim to do. So as I've mentioned, when I started, I think there was 2 clinicians in the business and I was the third. We now got 48 clinicians working across Home Group in a variety of settings, and that's across 7 disciplines. So we have OTs, PBS, we have physical health nursing, learning disabilities nursing, mental health nursing, social work. So we are growing, ever growing. We have a trajectory to be in 80 clinicians with us within the next 12 months. And they sit across 15 different roles. So what you will see within Home Group is we will have clinicians who do front-facing work with customers directly. So our occupational therapists will work with our customers to do that skills development piece, to enable them to get the most out of their life. But we also, quite interestingly, where we have, say, mental health nurses, unless, as you'll know, nurses work within a TDDI CQC registration, they're unable to work directly with customers. So what we have is mental health practice leads roles, and those roles are very much embedded within service, and they're about working with support workers, with PBS reablement workers, with a range of people to understand the complexity of the customers that they work with, to provide that scaffolding, that education, and that reflective practice for teams to enable them to better work with customers. So, we have a range of roles in there. We have nurses within practice development roles who really are supporting the infrastructure and the quality of the clinical provision that we have. And we do all of that in partnership. So we understand systems. I think that's what was really unique for me coming to Home Group, is working with people who understand social care, who understand health, who understand those pathways of provision, and going down to that integrating health, housing and social care. I think one of the biggest reasons I, as an OT, came to Home Group was that, having worked for 30 years, predominantly my background is frailty, complexity and dementia, and having worked in the community where the housing was the thing that let somebody down, their home environment just wasn't right to meet their needs, and coming to Home Group and supporting that opportunity for us to look at all those elements and wrap that around a customer. So if you think about our Transforming Care, we do just that. We work with partners in co-production to look at the needs of complex individuals who may have spent a long length of time in hospital, or in, for some of our younger people, in kind of educational environments. And we think about not just what will we need to do to support their social needs and their health needs, but what does that physical environment need to look like? How can we get that right from the beginning? So for some of our customers with autism or very complex mental health, that home environment is very critical. So for me, that was really unique as an occupational therapist. And I think that is one of our really great strengths. We try with our models, and I think Chloe will cover this, it's about how can we support organisations such as trusts build their capacity. So some of our models are about that supported discharge out of hospital. For me, our older people's offer is very much about how can we work with older people to keep them enabled and engaged and to prevent them requiring to go back into hospital. And I think that permeates across all that we do, which is working in partnership. And I've put there bespoke models, because we don't do this in isolation. This is a partnership approach. This is working with partners to understand what their needs are, what they see as some of the blockages, what they see as some of the opportunities, and how can we build capacity across that pathway of health and social care into the community? How can we support individuals with quite complex needs staying in the community and not needing to come back into secondary care? So I think if I was to sum my last bit up, it would be about that co-production and partnership, working with all of you, that is absolutely critical for us getting this right. And going back to that, one model doesn't fit all. We don't want to put individuals in a model that, and in a service that doesn't meet their needs. So that's why, for me, when I look across Home Group, all of our models are slightly different. They're tailored to locality, individuals, and those partners that we work with. So I know that Chloe will be coming on to talk in much more detail with you about some of those models. But that, for me, is what, in a nutshell, what we aim to do.
Thanks, Lindsay.
Yeah, thank you.
Yeah, so just to kind of introduce myself, I have worked for Home Group for nearly 2 years now under the new models of care, and working alongside Rachel and the clinical team to look at partnership working and to really kind of put the word out how the importance of health and housing and that partnership really is. So I am also from an NHS background predominantly, but kind of providing services to reduce out of area placements and various roles within the NHS, but not as a clinician, I must add. So I wanted to kind of bring to the table today the different types of models that we do operate nationally. So these are not all the models, but it's to give you a flavour and some examples of how bespoke and different they are, but how they are so imperative to supporting that particular area. So first I wanted to go into the Birmingham Mental Health Carers Service. So this kind of came about when the legislation for the Carers Act 2014 was brought into place. And that was that each healthcare setting must have a carer lead who identifies carers and signposts them to appropriate support. So this service has been going on since 2015, and it supports customers from the age of, well, it's any age, but at the moment we have somebody as young as 4 years old, right the way up until 92 years old. So it's a very variety of service. So we have services such as allotments, where we get them involved with the community. But the kind of aim and the commitment of that service is to reduce the impact of caring for someone and the impact that it has on their life. So to make them feel individual, and so they don't lose sight of their goals and ambitions. So to access the service, you must have a mental health need, and we will work with those customers in supporting their recovery. The next one, Gloucester Community Wellbeing Service. So again, a very unique and bespoke service to Gloucester. It's a kind of social prescribing service, and with this one, we aim to help customers make the local connections. So a lot of the time, especially with COVID happening, there is a lot of social isolation. So our service is, during COVID, it was remote, but prior to COVID, and now we are based in a leisure centre right in the centre of Gloucester, and we have our colleagues who create bespoke support plans for customers and check out what their needs are, their goals, their ambitions, how they're feeling, where their kind of mental health or physical health is failing, and put plans in place to help support them get to where they want to be. So the service has a lot of signposting within that, but a lot of support around physical and mental health wellbeing as well. The next one, Cornwall Empowering Independence. This is physical health only, so you must have a disability or learning disability in order to access this service, and it supports people from age 18 plus, and that is all around how to secure housing, that maintaining of accommodation, the managing money, accessing any education needs, developing healthy lifestyle skills, and increasing that social inclusion, which is often the case with learning disability. So that service has been going on now for over 10 years, and it's making such an impact to Cornwall. The next one, our Durham Wellbeing and Recovery, is again for age 18 plus. That's a floating support service. There's also open access groups and volunteering or befriending services. You can access that service with a mental health or learning disability need. And we deliver one-to-one support, group support or remote support to the customers within Durham. And that kind of aim and focus of that service is to reduce the requirement of inpatient facilities. And again, customers are provided with personalised plans to start their recovery. And again, it's all about listening to the customer and finding solutions to work with them and what's available to access in that particular locality. The next one, STEP, which is Sustaining Tenancies and Enabling People, is a new concept for Home Group and very bespoke to Home Group. So we've listened to kind of the demands in the community and within hospitals and local authorities. And this is mainly focused at people who have difficulty accessing housing or require some support to live independently. So this is very much focused on those that we struggle to house in the community. So it's kind of three elements to this service, and we would look at furniture packs, the transitions, so any housing related support in the home group properties that we have available, and the funding all comes through housing benefit. And then there's a floating support element to the service, which whether the customer has housing with home group or another housing association, we would fund the floating support through Section 117 funding, aftercare or social care for those that are eligible. So that is very much about housing and the need to get people into their own accommodation. The Link Wellbeing and Support Service, this works in partnership with the District Hospitals and Mental Health Services based in Somerset. And here we work within the wards. We have an accommodation set alongside that as well. But predominantly we work alongside ward staff in hospitals and complete the duty to refer. And we identify cases who will be an NFA, so no fixed abode, on discharge. And we would either place them in our accommodation. We have an 8-bed step down unit, and we would work with them for up to 8 months in securing their own accommodation, or we would work with other social landlords or housing association to secure that accommodation, and then provide an element of floating support with them. A big kind of key area of the link is customers must complete what we have as a home achievement programme. So this is fixed modules which customers have to complete in order to access the service, and this will give them skills and education around health and well-being, employability, promoting independence and social responsibility. So there's hundreds of modules for customers to complete, but yeah, in order to secure that tenancy, they must tick certain criteria for that one. And as Lindsay touched on earlier, we do have mental health hospital discharge services, various models around the UK. We're just currently embedding one of our largest services at the CNTW Trust. And that is about working with the trust to support people being discharged from hospital and prevent that recurrent readmission. So often customers are discharged with very little support in the community. So that readmission piece is key, and the prevention of that. And then we have a discharge to assess. We have a couple of these models operating in the UK. So we have some community wellbeing schemes, quite large schemes set around the UK. And this particular service was supporting the customers in Reading who could be discharged. They were medically fit to be discharged, but needed some assessments. So we moved them into our community wellbeing schemes. And I'll go through some outcomes on the next slide. But yeah, just to kind of pin home again, the kind of community models all have that national floating support element to them, and we focus on homelessness, mental health and learning disability within all of the models. So it's not just we can only support customers with mental health. A lot of our models do incorporate that homelessness need or learning disability as well. So to look into some of our outcomes, to really drill home how much of an impact these are having on the community. So our STEP model had an average cost reduction of £245 per person per day. The hospital discharge service that we initially run a pilot for at the CNTW Trust had a reduction of 100 days of hospital stay, which saved £35,000 per customer. And some of these figures are provided directly from the Trust, or we use WebWEMS, which is a Warwick Edinburgh mental health wellbeing scale as well, just to let you know kind of where these figures are coming from. The discharge to assess service had a 40% cost reduction for the local authority and improved assessments. So key kind of, I think, area for this discharge to assess were the areas where they were previously getting discharged to just weren't fit for purpose, whereas our property had that ability for the customers to make their own cups of tea, make toast, and the clinical staff that came in to kind of complete the assessments could really monitor the physical abilities of those customers in a much better environment. The Durham community model, 47% of customers have had less support from their GP or hospital admissions due to the support from groups, which is a key area for us to focus on. So it's not taking that work away from hospitals or GPs by any means. It is that supporting pressures and allowing hospitals and GPs to deal with customers that have more severe or complex needs, whilst we can support with those more low-lying support needs. The Empowering Independence service, so 48 customers have reduced the need to access social care since October 21. The Carers service, now this is a very impressive figure. So 4,976 customers have been supported and reported an improvement in wellbeing since the service started in 2015, and that's had a social value saving to the NHS of £38 million for all those customers since the service was launched. And I must say, with that service, we've had people visiting from international areas to see how that service operates. And all customers across services have reported, according to our WebWEMS stats, a 76% increase in wellbeing and health. So really impressive figures there across all services, and that's just a flavour. What I will add for any of these, the kind of support types that we implement and focus on with customers is all about that peer support, volunteering, training, healthy eating, physical activities, supporting accessing housing or benefits, and self-improvement and confidence building. So for us, I will say we are not trying to represent any ward or hospital setting by any means, but it is using that skill and knowledge of our clinicians to understand the needs of people with learning disabilities or mental health and how our housing can prevent. So a report from Shelter did find that 1 in 5 experience mental health breakdowns due to a housing need. So it just completely makes sense for us to form that partnership and prevent that from happening moving forward. And that's it from me in terms of that. And is there any questions from anyone? Or anything that anybody wants to add further?
Well done, Chloe and Lindsay.
I will say as well, with these models, I've only given a flavour of them. So we have various videos and service leaflets and business development and sales teams. So if anybody's wanting to have a conversation about how these models operate day to day in more detail, or how a combined model, if you've heard any of those bespoke ones, may work in your area, then please do let us know, and we're happy to have that conversation.
I think it's worth adding. So whilst the numbers and outcomes are brilliant, it's, you know, it's a one-liner on a slide, and then some of you, I'm sure, in your mind will be thinking, really, is that right? How can that work? So we have got, I think, 3, but definitely 2 independent evaluations of some of those services. So if you wanted, I wouldn't send it out to everyone just on the call, but certainly if you wanted to come back and ask to have a look at those independent evaluations, we could do that. And I think it just gives you reassurance that somebody else has done it and found out what we achieve. And the carers one, everyone always thinks, what, 38 million? But it has been running a long time.
Yeah.
And the really that saving comes from, I think it comes from the WebWem. Is that right, Chloe?
It is. So it's all around the social values. So that prevention of hospital admission and the need of social care or GP care.
Also, when I'm not as up to date with it now, but when the service, well, not that many years ago, it was really about the children. So it's about children caring for their parents in the home, because you know, and not creating that separation. So I assume that a lot of that cost is what would happen if that parent went into hospital, and those children would then need to go into care, and so it all built up. But it started, I was there at the beginning of it, being about supporting children who were caring for parents at home from a very young age with not a great deal of support. Anyway, I'll shut up now. I've got a hand up.
Yeah, we've got a
So
few
let me go
questions
to,
as well.
let me do that now. Let's go to Paul.
Hello there. Thank you very much for that. Yeah, I'm interested in some of the headline data that you put out. How is it you're calculating less support? 47% reduction in admissions and referrals to GPs. How is it you're getting to that figure? Obviously, there must be some research behind it. And the other one, to do with hospital reduction, 100 days. Is that per client, which equates to 35,000 per patient?
Per patient, yeah. So all the data and stats. So we look at the data of the trust before our service implemented. So how many days they spend in hospital. There's full Excel reports that the trust and ourselves work on. So we have dashboards that we produce on a monthly basis that looks at all that detail. And we do have some examples and have authority to share some of them. So I'm more than happy to forward them on to you, Paul, or anybody else that's interested to see how that is calculated.
Is that benchmarked against someone else in hospital and with a similar condition? Is that how you've used it? So you're saying that due to your intervention, you've reduced their stay by 100 days, which equates to 35,000.
Yep, absolutely.
Right. Okay.
Thank you. And
Thank you.
Catherine?
Hello, my name's Catherine Cade. I'm a project manager, programme manager working in the NHS down in Cornwall. I'm just working with a group on the neurorehabilitation pathway, and I think I've got a similar question to Dawn Turner in the chat. Have you got experience of any models for adults with complex neurological conditions? And I think Dawn's question was similar. Are there any models for people with cognitive impairment?
I'm not probably the most knowledgeable. Lindsay might have a little bit of insight into that.
I think some within our transforming care, we certainly got some customers got acquired brain injury. In terms of more, yes, we do, but it's probably more complex and sits within our transforming care. I think some of the other services we may touch on, but it depends on the level of complexity that you're talking about.
Okay.
What particular, customer group you're talking about when you talk about cognitive impairment, but certainly we do have individual customers.
Thank you. Okay. Yeah, I may well be in touch outside of this meeting. Thank you.
Just catching up with the chat. I haven't missed anyone's. Paul, is that a legacy hand?
Yes, apologies.
It's all right. So in the chat, yes, about the recording. I think I need to check this with Chloe. Do you need to request the recording, or do we just send a link to everyone?
No, we send a link to everybody.
To everyone.
So
okay, fine.
We've now been doing these events for about a year, so we have a YouTube channel as well, where all these events are recorded, and past events that we've produced are on the YouTube channel. So after this, I'll ensure everybody has the link for that.
And just picking up on a couple of people who were later, yes, we send the slides to everybody. And I suppose the other thing to say is, if you read the slides and then got questions, you just come back to us. We have a lot of colleagues. We can always field a colleague to talk to anybody who needs to, get into a bit more detail on some of it. From general acute hospitals, oh no, that's Paul, yeah. Paul, do you want to say a bit more about the piece in the chat about, or have we done that, the step down models from acute?
So I'm aware of you running some mental health hospital discharge teams and some step down models for mental health. We're currently looking at something similar, I suppose, for coming out of general acute hospital, and just wondered, do you run anything similar at present, or is it mainly related to mental health?
I think I'd be safe in saying it's more about mental health, but okay. And then the other bit was what Chloe described, which is less about mental health, the discharge to assess. So this is being able, in some ways, that's more of a housing offer that we're allowing people who are technically ready for discharge but need to test out a few things like around their physical health or being able to cook and so on. We are able to do that in our big community wellbeing schemes. A community wellbeing scheme, just for information, is like an extra care, but we do it differently. It's not just extra care, and we have a health element to it. We've 4 very big ones, 2 built in Leeds and the other 2 being built, one in Reading, one in Scarborough, and one over in Cumbria, and I'll have missed one somewhere else, but they're becoming a dominant and welcomed force in home group for us to be able to do that.
Thank you.
Any more questions? Have I accidentally missed anyone?
I don't think
okay.
So.
Well, there's no harm in finishing early. You know how to get in touch with us.
We do have one. We've got.
We have one now. Yeah, sorry.
Sorry, Rachel. I was just following on from your last comment, really, about your community wellbeing schemes being different. How different are they when you talk about that health side of it?
So we come at it from a very reablement point of view. So what we don't want to do is take people in, get their care package, and not be involved. We want to see people thrive. And so we have, I think, I mean, actually, I'll ask Lindsay, but I think even the colleagues have that reablement bit in their title and are trained in that way. Go on, Lindsay, you know much more than I do.
No, I think what we try and do within community wellbeing is, I suppose it is what you would see traditionally as extra care, but what we've tried to move it to is very much that these would sit within communities. So for me as an OT working with older people, I've always felt that extra care, sometimes we almost house older people in a way that keeps them safe but doesn't engage them in the community. So the premise is that community wellbeing has got to be lively and engaging. So we will have community cafes in there. We have that, you know, there's one just opened a few months ago in Gateshead, and when I went the other day, there was families in there, there was opportunities for other services to come in. But actually what we did was we tried to move away from our support workers. So all our support workers are trained from a reablement focus through occupational therapy, with that notion that what we try and do and work with commissioners is, rather than have individual packages where we know, say, somebody's commissioned to have 3 hours support a day, what we try and do is block. So can we do some block contracting around the hours? That what allows us to do, because we know to re-able somebody who's older takes more time, but actually the benefit over time when people are more independent. So we work from that premise that we will work with people to re-engage them when they, particularly when they come out of hospital or they've had those moments where they're perhaps frailer. We work with them to keep them independent and to enable their independence, and then reduce the support that they require. So all our staff attained. My ambition when I came was always to perhaps have, you know, step down beds in there or intermediate care, because so often I saw spot purchased intermediate care from nursing care homes, and that's not the right environment for reabling people out of hospital. We know people that are older take longer to recover, and instead we put them in environments that maybe don't support that. So, you know, that was the premise of community wellbeing, with a view that potentially how you can use that in a different way. But certainly we also have, particularly in Gateshead, we've 12 bespoke flats for people with dementia, and I certainly was keen that they were not in a wing separate to, because we know that, you know, older people will support each other, and actually some of those older people in those flats are now full, and those individuals are fully engaged in the environment. So a lot of those kind of principles that sit behind.
It's interesting too that I think if we hadn't gone down the path of a clinical infrastructure into Home Group and then all the clinicians, we would never have got to those levels of design. I'm probably stating what's obvious to you all, but that, you know, Lindsay and all the other clinicians just influence what we do and change it. And that's the joy then, that we are able to deliver services that are, I think, just a bit more up to date. And
we also have physical health expert Leslie, and so what the community wellbeing able to do is, so just last week she said they came to her and said, oh, we can see somebody's spine. So she, you know, when she looked into it, was a pressure sore that might have been missed. So we enable, then the support was to access and get the right people in and set up that support around them. So we have that oversight of a physical health expert who has done a lot of work nationally around frailty and complexity.
Any more for any more? We're done. You get 15 minutes back of your life. So thank you so much. We've had a great response. I think we had 55 on the call at one point, so very pleased about that. You know where we are. We do this to help create other models, and we are national, so hopefully we hit most areas. So talk to us if you're interested in any of the detail, actually, or if you're interested in us working with you to look at a proposal. Chloe, have I missed anything?
No, I'll follow up with the slides, and there'll be a little survey link. So if you can complete the survey, just to let us know kind of what services you're interested in hearing about in the future, and we can ensure that the events are kind of aimed at what you're interested in listening to. That'd be great.
Great. Thank you so much, everyone. And thank you, Lindsay and Chloe.
Thank you.
Thank you.
Go.
Thanks very much.
Bye.